Hi, this is Dr. Bob Dannenhoffer, Public Health Officer from Douglas County with another of our Facebook updates. It's February the 9th, and this is now almost a year that we've been doing these Facebook Lives. Time for you to ask questions. Many of the people put them in our Facebook questions at douglaspublichealthnetwork.org, and we'll get to those first, but if you have questions, I put them in the chat, and I'll try to get to them as best we can. As always, we start at the top and then move down. And the good news in the world is that the pandemic is slowing. The number of cases in the world, the number of cases in the U.S. is clearly declining, and the number of deaths is now also beginning to decline. Also in the U.S., we're seeing hospitalizations are declining, and so I really think we have made very good progress over the last few weeks. In Oregon, actually, our case count is about steady. Some of that is because we were very low to start with, and when you're low, it's pretty hard to go any lower. In Douglas County, similarly, we were very low, and we've been just staying at pretty much that rate until this week, where we're really seeing an explosion in the number of cases. And that explosion in the number of cases is really concerning. We had 35 cases today. 2 separate outbreaks, one at a long-term care facility, and then another at basically a bunch of outbreaks at schools. And so we're seeing a little increase, a little uptick in the number of cases and the number of outbreaks. And that really is concerning because when you get a lot of outbreaks, it's sort of hard to figure out where they all came from. So we're a little worried about that, and we'll see what happens over the next few days. But now is not the time to let our guard down. You know, they did the risk levels yesterday. We remain in the high range, but not by much, so that if we continue to have the same number of cases we've had over the last few days, we're not going to be in the high range next time, and we'll have to close down businesses, close down restaurants, close down gyms. I really, really, really don't want to go there. So let's keep working on it. Again, lots of interesting stuff about vaccine and variants, but I'm sure we'll get to it. So Joyce has a long question here. As after the first dose of vaccine, 80% of the population had immunity to COVID. After the second dose increased to 95%. We don't know if the 80% had a lasting response or a true T-cell response because that was not studied. Is that correct? And the answer is yes, that's correct. Because the studies on the Moderna and the Pfizer vaccine were to determine effectiveness after a minimal time between first and second dose. T-cell response was not studied in either group. However, it was thought that T-cell response was good because after the second vaccine, you had increased level of antibodies. I was a little bit late today because I was just watching a video about what's the optimal timing. And actually, this study suggested that the Pfizer time at 3 weeks and Moderna time at 4 weeks really should be considered the minimum, and that actually waiting a little longer, you actually seem to have a better response. And that would be not surprising. That would be typical of other vaccines, where we typically wait a while between the first dose and the second dose with vaccines. So we do know that patients receiving the second dose had a T-cell response. Well, we're not sure it was T-cell response, but we do know they had increased antibody response, suggesting there was immunologic memory. So what's the optimal timing for the second dose? Nobody knows. We know that's certainly going less than the 21 days for the Pfizer or less than the 28 days for the Moderna. It really isn't studied. And I think the CDC was pretty clear this week that nobody is opting for more than 42 days. But I think the data between the 21 or 28 days and the 42 days is all within the area of uncertainty. Now, some people have suggested holding off on the second dose for even longer, 6 months or longer. I think the CDC suggested this week that shouldn't happen. So I think we're kind of done with that. So somebody said they're expected to get a vaccine this week. What dose? Which kind should you get, a Pfizer or Moderna? I think the answer is you've got to take whatever is there. I think the difference between the Moderna and the Pfizer is really infinitesimal. And so I don't think I would make any differences there. So I would just take whatever vaccine is available. The Pfizer vaccine is being mostly now shunted to big places like Salem and Portland and the hospitals. So actually you'd have a really hard time finding a Pfizer dose here in Douglas County. So someone says, I received a vaccine on the 30th. Aside from being a bit tender, sore, and a little red, I felt fine. However, 7 days later, a little Hyvee spot at the injection site. And so what should they do? Well, that would be unusual to have a reaction a week later. And I would certainly have you talk to your doctor about that. Certainly, anytime you give anybody an injection, a poke anywhere in the body, you're making a hole that can get filled up with bacteria. So redness a week later could be something else. It could be a reaction to the Band-Aid they used. So I would certainly have them talk to their doctor. So remember last Friday, I was a little maybe under the weather. I got my vaccine on Thursday. And on Friday, I felt just tired. I probably don't get enough sleep anyway, but I felt really tired on that day and went home and then slept the rest of the night and felt fine by Saturday. So this question here is, after receiving a COVID vaccine, a friend reported brain fog and other cognitive symptoms. Is there information on possible cognitive side effects in response to the vaccine? So in the studies, there was a lot of people who reported fatigue after the second shot. However, they didn't do the kind of cognitive studies that would help pick up on brain fog. And this is so fascinating. You know, we get 3 minutes to talk about something other than COVID. So, over the last 10 years, we've really been worried about concussions, especially concussions in sports. And so in the past, people would get hit on the head, and the next week they'd say, I'm just kind of in this brain fog. And there were anecdotal stories because people would, for example, take the SATs, get a 600 on the SATs, get a concussion, retake them and get a 400. It's like, whoa, what happened? And he says, I just couldn't concentrate on the test and I did badly. After a few months, they would take it again, they'd be back up to 600. So actually, we started doing these tests on athletes before the season and then after concussion. And what is remarkable is that after concussion, although these people look okay, they're terrible on these cognitive tests. And the cognitive tests are not all about intelligence. Some of those is just mental processing. So one of the ones similar to what they do is you have all the letters and all the numbers on a page, and you're supposed to connect A1, B2, C3, D4. And, for most people, this is like, I just can do it. Well, after people get a concussion, it's like, what comes after B? And they struggle with this. And so it's really remarkable that after concussion, their performance goes down and then comes back. If they had plenty of time to study this, they really should have done cognitive studies before and then after to see if there's a cognitive decline. And there probably is some smart researcher out here that's doing just that to tell about the brain fog. But as best I know, they did not do any cognitive studies looking for brain fog. And absent those studies before and after, it's really hard to tell. But yeah, it's really, the amount of fatigue I had, it wouldn't be surprising that some people might have some mental slowness. I actually did a bunch of puzzles those days. I love doing Sudoku and other kinds of game puzzles. I was still as good, so I didn't at least have brain fog that day, but perhaps other people did. So Marianne says, one of my family members who recently had COVID, recovered, tested negative, and is back at work. I read that people can still shed virus some weeks after having COVID. Is it safe to be around them? So when you have COVID, you don't need a negative test to tell you're cured. What we know is that people with normal immune systems who have mild or moderate disease never shed transmissible virus after the 10th day. So they never can spread it to anybody else after the 10th day. Even the sickest people in the ICU or people with immune suppression can never spread it after the 20th day. However, we do know that the mRNA that's associated with this virus can stay in your nose for a very long time, an average of 24 days, but we've seen it up to 2 or 3 months where people continue to test positive by the PCR test. And so our point is that you're no longer infectious after 20 days, but you may still shed RNA for weeks thereafter. So yes, it's fine to be around him. So Donna says, I'm 67 and will be eligible for the vaccine March 1st. Well, I have to wait until everyone eligible ahead of me gets vaccinated first. Unfortunately, I think that is correct. So unfortunately, in this descending age stair here, with the little bit of vaccine we have, there are going to be some 80-year-olds who are not going to get vaccinated until February the 20th or so. And then you have all the 75-year-olds. They may not get vaccinated until March. And so even though you're eligible for the vaccine on March the 1st, you may not actually get the first dose of vaccine until April. And this is really, really, really unfortunate. We've made these increasing eligibility before there's a vaccine to cover them. So it's as if you're borrowing Peter to pay Paul, and then you just keep having your debt go out and out. So borrowing from the payday loans to make up for the payment you owe the next week, and soon you're going to fall farther and farther behind. We think that by April, we're going to be about a month behind on giving vaccines for seniors. It is truly tragic. So if I went to the dentist today, this afternoon I found I was exposed to COVID, do I need to contact the dentist? I don't have any symptoms. Very fact specific. So it means when you were exposed to COVID, what your exposure was to the COVID. So for example, if you went to the dentist today and found you were exposed to COVID this morning, the risk at the dental visit would be very small. On the other hand, if you went to the dentist today and you found that 5 days ago you were exposed to COVID, that would be very different. So it's again very fact specific, and it'd have you call the hotline and talk to them. Clearly, if you develop symptoms, if you've been exposed to COVID and you develop symptoms, you should certainly get tested. All right, so Louise says, I totally support the idea of local distribution of the vaccine to pharmacies and clinics. My question is, with so little vaccine and so many points of distribution, it seems that allocations to each location could be a challenge. Can you comment how you're approaching this? It's an incredible challenge, and that's why when you have big challenges, you ask extraordinary people to help you with those. So at Aviva, there are several really extraordinary people who've helped us with these distributions. At Aviva, Liz spent all day today delivering vaccines all over the county, and yes, it is a challenge, but we consider that the challenge of Liz having to travel to places around the county is totally outweighed by the fact that we can have hundreds of seniors not have to travel all the way to Roseburg to get it. There was somebody, an EMT from Lower Umpqua Hospital came today. So by being able to deliver that vaccine to Lower Umpqua Hospital, all of those people didn't have to travel. So yes, Louise, it is quite the challenge. I spent until late last night trying to figure this out, but it's a challenge, but it's worth it. It's worth it. I mean, when I look at what other counties are doing, they're having seniors sign up and put their names on the list, and maybe weeks later we'll call you. Oh, so much better to be able to call your doctor and get in. Now I know there are a lot of people who have called their doctor and their doctor says, geez, I'm already out of vaccine. And I know that's it, I can't make more vaccine. Or they don't have a doctor in town and they call the pharmacies and the pharmacies are out of vaccine, but we'll get there. Yeah, so Bruce says, I thought long-term healthcare got vaccinated. Why do we see an outbreak? So this data not yet published, but what we saw was that the vaccine worked great at about 90% effectiveness. The people who brought this in, or the people who got infected were largely people who were unvaccinated. Again, people don't have to get vaccinated, and we know that among workers in long-term care facilities, a good number have refused vaccine, and among patients, some have refused vaccine. And sadly, those were overwhelmingly the people who got ill. So what percentage of long-term care residents have gotten vaccine in our county, Judy asks. Really complicated. Long-term care is about 40 different ways that people are in long-term care. When we talk about people who are in long-term skilled nursing facilities, so skilled nursing facilities where you have RNs and LPNs and other kinds of skilled nursing there, the highest level of long-term care, about 80% of the patients and 50% of the staff got vaccinated. That's pretty low. When you get to other kinds of what could be considered long-term care, like over 55 communities, or sober houses, the number is much, much bigger, and the number of been vaccinated have been much, much less. So Bill says, my 91-year-old mother's provider isn't doing the vaccine. Where can she get it or be notified when it is available? So for people whose provider is not doing the vaccine, we've arranged with the 3 Bi-Mart pharmacies in the county, the Fred Meyer Pharmacy, and Gordon's Pharmacy to provide vaccine. We understand that by later in the week, the 2 Albertsons and the Costco Pharmacy will also have that, and so that is what we're requiring. So Sue says, I've had both vaccine doses, but my surgeon is requiring a negative COVID test. Could I explain this? Well, the vaccine is good, but not perfect. So again, we think the vaccine is at least 90% effective, but that means that 10% of the time it could not work, and you could still have the disease, and they're really looking not to bring COVID into the facility. So the good news is if you've had 2 doses, you're much less likely to be positive, but still requiring a negative COVID test is not illogical. Yeah, so Michelle says, are the new large groups that have COVID the original strain or the newer strains? We don't know. And so the story is the newer strains or the newer variants, you have to actually do DNA sequencing to find those newer variants. That takes weeks. And so these outbreaks just happened in the last few days. So it's going to be a long, long time to know about that. Unfortunately, way beyond the time that you're making quarantine and other decisions. There is really a hope that we're going to be able to get some more rapid genomic testing in the United States so that you could find out within a few days whether these are the same virus. And so we have no clue whether these new large groups have the original strain or the newer strains. There's nothing funny though about these outbreaks. There's nothing, they're kind of like you'd expect. People did things that they might not have done. They are co-workers at a long-term care facility who didn't get the vaccine, or they are people who didn't wear a mask, or people who gathered, and that's how it spread. So there's nothing unusual about this. But it would really be great if we knew, right? If within 5 days of submitting the specimen, you could tell whether it's a variant strain or one of the old strains, that would be reasonable. Jennifer says, how do people with no doctor in Reedsport get the vaccine? So just on the phone yesterday with the people from Lower Umpqua Hospital, they're going to have a call center in Reedsport to deal with the Reedsport patients. As I said, we just sent them vaccine today. Yeah, Paul says, how well is our county getting their share of vaccines compared to other counties? Seems we have been snubbed. I think you are, Paul, you hit that one on the head. So I've tried to figure this out, and this is what I have found. So what I found was that early on, the big vaccine distributions went to large, multi-county healthcare systems. And in Oregon, there are a few. There's Salem Health that does Salem and Marion County and Lincoln County and Marion-Polk County. There's OHSU, which does the Tri-County area. There's Asante, which does Josephine and Jackson counties, a little bit of Klamath County. And then St. Charles, which does lots of places there. And so there was a tremendous amount of vaccine that went to multi-county areas. The problem is, when you look at those multi-county areas, there's no Douglas County in there, so we got screwed on that one. The second was that early on, there was sent to health departments, and they kind of sent every health department the same amount of vaccine. Like 36 counties, everybody gets the same amount. Well, if you were a tiny county with 1,000 people, 500 doses was a lot of doses. However, in Douglas County, 500 doses was not a lot of doses. And so the little counties got it, and the big counties who had health systems got a lot, leaving the counties in the middle kind of low. And they've admitted that they were low, and we did get a little bump up in our vaccine. But still, when I look at the amount of vaccine we've gotten, we have really gotten short shrift. And we wrote letters today and talked to the governor's office today about this, because I think we're still short shrifted. I checked today, and it looks like we've given out 86% of the doses that have arrived in the county as of Saturday. And so it's pretty good. I mean, there are a couple of doses hanging out there for second doses. There's a couple of doses hanging out there for other things, but 86% is higher than any place around, and yet we're the second lowest county in the state. How can that be? Well, because we've gotten the lowest amount of vaccine, and so we're really, really looking for the state to rectify that. They can't fix what they did before, but they can certainly fix going on in the future. Amy says, how much do we know how much of an impact did the 500 doses going to prisoners have on our local supply? Well, some. So the story is there are about, by the time we get done with it, they're going to have about 20,000 doses for state prison inmates. We get about 4% of the thing, so it's 800 doses. So 800 doses would have been nice. Now, the question is, what should we do with people in prisons? The people in prisons and the outbreaks in prisons are really, really problematic, and they've been problematic for months. And they've been problematic for months for a lot of reasons. One is there have been a lot of cases, there have been a lot of deaths. So there have been almost as many deaths in the prison population as there have been in Douglas County. So there's a lot of deaths. So it is worthwhile to go ahead and work with that. In addition, people who are in prison leave prison. And we've had 100 or so leave prisons where there's an outbreak. The amount of worry that we have about them is enormous. So they come out, they have to have special transport. We then have to house them and feed them for 2 weeks. They're not under any lock and key, so they leave and they can infect other people in the community. So the outbreaks in the state prisons have had an enormous impact on us locally. And we have a couple of people on staff whose job it really is to deal with our guys from the prisons, and they're mostly guys. And it's a lot. Well, I cannot tell you how many thousands of dollars we've spent housing and feeding them because they've come from prisons where it's endemic. If everybody could get a vaccine, the disease is going to go away in the prisons, or really get much less, and it's going to make our life a lot easier, as well as it's going to prevent some deaths, because there really have been a number of deaths. So this whole immunizing or vaccinating prisoners is really a complicated thing, but it really does have an impact of what's going to happen in Douglas County. So Tracy says, how many vaccines will be done in the drive-through in a day? I'm not sure. So there's a bunch of different ways to do this, right? So the Aviva has set up these big events at the fairgrounds. They're drive-in, but you still have to walk in and do it. Drive-throughs are a little problematic for this vaccine. And so I don't know if anybody's actually planning a true drive-through. So, we've done a lot of drive-throughs with the flu shots. We've done a lot of drive-throughs with the nasal swabs, I think over 100 now. And those were fine, right? Because people, when they get the flu vaccine, almost nobody has a reaction. In fact, all the years we do this, nobody has any reaction at all. So you can give people flu shots, have them wait around for 15 minutes, and then they can go with almost no sense you're going to need to do anything. This one's different. This one, we have seen some minor reactions, no major reactions, but some minor reactions. And I'm not sure you want to be dealing with in a parking lot in somebody's car. Now, some places have done it. So we're not sure about drive-ins. Certainly the events that Aviva's done at the fairgrounds have been great. Very safe, lots of doctors around, and that's been okay. The problem is not how many can you do. The problem is we don't have enough vaccine. So we distributed, I can't remember the number of vaccines, but we distributed about 1,900 doses today. If I'd had 5,000 doses, they would have been snapped up before noon. So the problem now is not enough vaccinators, not enough throughput, whatever. It's clearly not enough vaccine. So the other Tracy says, how do you sign up for a vaccine? My father's 77 and needs one. So we would ask your father on the 15th to call his regular care provider and to get on the list to get a vaccine. So we think about 90% of the seniors in town get their care at a place that's going to give vaccines. If he does not have a provider, and I would hope at 77 he does, or if this provider is not giving vaccine, then he should sign up with one of the pharmacies, 3 Bardmont pharmacies, Fred Meyer's, Gordon Drugs, and next week we think Costco and Albertsons. So Ralph said, with so many clinics receiving doses, how is distribution assuring the oldest age group is completely vaccinated for those who request it before starting in the next group? So these are clinics we work with. They're partners. We talk about the guidelines. They have questions about the guidelines. They do it. And so that's the guidelines. Now, we're not requiring 100% accreditation that they have never given at a different age group, but generally they are following the rules exactly. So for example, in the pharmacies, we ask them to do just people 80 and above. They've agreed to do that. Next week they'll do people only 75 and above, and they'll do that. So they've generally done it. Now, you'll occasionally hear stories, and this was one that's going around, that, oh, everybody's wife gets a vaccine. Well, my wife hasn't. But what'll happen sometimes is you'll do the vaccines. There's supposed to be 10 doses of the Moderna vial, but sometimes you can get 11 and occasionally even 12 doses. So you've scheduled 10 people to come, you give them all their vaccines, you say, hey, wait a minute, I was able to get an extra one here from the vial. What do you do with it then? What we're asking people is please, please, please don't waste it, right? Far better in anybody's arm than in the trash. So what'll happen sometimes is, you're down with it, you've done all the 10 people there, you get one extra dose, and that was your standby that you had there, and then you say, oh my goodness, I got a 12th dose out, and you could give it to anybody then who's otherwise eligible for the vaccine. So that's how we're doing it. I think pretty much our vaccinators are following the rules. So Catherine says, you said last week it would be okay to go out of the county to get the vaccine. Is this correct? Yes, because those large hospital systems that got vaccine, St. Charles, Salem Health, OHSU, ostensibly they got it because they were going to do anybody in the state. So if you go to one of those big places that got all these really massive numbers of vaccine. So to give you the sense, St. Charles in Deschutes, a county not twice our size, got 17 times the amount of vaccine in one weekend than we did. And because of that, they started giving it to people from anywhere in the state who got it. So yes, if you want to go out in other areas, that would be fine. Now again, we don't have any of the big hospital systems here in Douglas County. So what we're getting is just for Douglas County residents. But yeah, I think in Salem Health, they got so much vaccine that they're expected to do anybody who shows up. Now, I'm really not encouraging people to drive around the country looking for it. And it would be so much better if we would have some kind of equitable and clear distribution system in the state. We're not there yet. So Julie says, do I know the percentage of educators who received the vaccine? So it's complicated because the educators include K-12, about 2,900. They include child care. They include early learning. We think all of those together would be about 4,400. But it's complicated because about 4,400 is only really about. I mean, the state rules are both so specific and so vague that if somebody said, no, we exactly look at the number, it's 3,400, I'd say, yeah, probably right. Or we exactly looked at it, was 5,400, I'd say it's probably right. So it's 4,400 plus 1,000. Let's say it's 4,400. And we know that about at the events that Aviva did, that about 1,000 people in that group got vaccinated. We know that in Reedsport about another 60 got vaccinated, in Glendale about another 40 got vaccinated, and then in our various clinics around the area, we think about another 300 got vaccinated. So roughly about 1,500 out of that 4,400. So roughly, but again, those numbers are off because of the many vagaries. So we think it's about 40% that got the vaccine among educators. Now I'm still every day getting, oh, I forgot, I was out of town, I forgot, I didn't hear it. Or what we're seeing increasingly now is all of my coworkers got it, they seem to be still alive, so now I want to get it. So we're these sort of late catch-up people, so we'll see. So Kat says, how many deaths have been associated with receiving a vaccine? I don't think any. So are you talking about people who had a vaccine and then died, we think, because of the vaccine? I think the answer is none. Now, what we don't know is, somebody might have gotten a vaccine a month ago and then died this week, and we don't really know about that. We do not think there's any that have been associated with receiving a vaccine. Now, as I said, there was an outbreak at a long-term care facility where most of the people, the overwhelming majority of the people who got sick had not had a vaccine. There were some who had had a vaccine, but I don't know if you'd say that was associated with. So you need to be a little, if you could be more specific about the question, we'll get to there. So why is Lower Umpqua Hospital the only vaccinator in Reedsport? They're not. So the two vaccinators in Reedsport are going to be, it's Lower Umpqua Hospital and the Dunes Clinic. And I talked to Paul Connolly, who's their CEO, yesterday, and they're going to set up a call center to have a place where they're going to give vaccine on a more regular basis. So he told me it should be up in the next few days. So I'd have you look for it there. Again, we're not looking for the people from Reedsport to have to come all the way to Roseburg to get a vaccine. We want to do it. And when last we checked, Reedsport had, and I wrote this down yesterday, Reedsport had 678 of about 5,000 people in Reedsport vaccinated for a rate of about 13%, which would make one of the highest vaccine rates in the country, actually. So they're doing a great job so far. Have they gotten everybody? No, because they don't have nearly enough vaccine. They would have loved to have 400 doses today. The most we could give them was 50. You know, there are places who wanted a lot of vaccine, 200, 300 doses. We gave them 10. And it's not because we were cooking the books here. It was just so little vaccine to give out that, we were treating each one of these vials as the precious thing it is. All right, we're going to get some more questions here. A couple of things. One is this variant stuff. It's really very, very interesting and very concerning. So again, variants are every living organism changes with time. Most mutations are going to be nonsense mutations, aren't going to make any difference at all. Most other mutations are going to be not very effective, and they're going to cause you to die off, but some are going to cause you to survive and prosper and to have more progeny. So we've got a bunch of different variations, but imagine in human evolution, if there was a mutation that made you twice as strong, well, back in the old days, when the stronger animals survived, you could imagine that mutation that made you stronger would now propagate, and the one that didn't make you stronger would go away, and then soon everybody would get stronger. And that's how mutations work. Similarly, with these virus variants, the ones that spread better and the ones that are more infectious do seem to spread. So the big ones that we're looking at, and these are all very complex. They're not just a single mutation. Some of these are all groups of mutations. There's the UK variant, which is spreading in the UK, which does seem to make this more contagious, maybe more deadly, but doesn't really seem to change the way the vaccine works. The South African variant is much more concerned because it appears to be both more contagious, more deadly, and seems in some cases to be able to escape the vaccine. So you may read a thing about the AstraZeneca vaccine, which seems to work well in other places, doesn't seem to work very well at all in the South African variant. So that is a worry. There's the Brazilian variant that we know much less about. Again, Brazil's not done a lot of genomic stuff, so we don't know much about the Brazilian variant. And then there's the Southern California variant that seems to not make as much difference. But what's going to happen is these variants are going to spread around, and when that happens, the real concern is that the vaccine will not be as effective. And with the vaccine not being as effective, we could be right back to where we were before we had a vaccine. Oh my goodness, we don't want to go there. Okay. So my non-frontline worker in Lane County said she got to sign up to be in a queue to be vaccinated when it's available. Any goal to do that here? Samantha asks, well, yeah, there are some places that are signing people up in a queue. So the queue for non-frontline work in Lane County is going to be sometime in May or June. I mean, I'm not sure that it makes any sense to have people sign up for something that far in the future. I mean, we could do it. We know how to do it. But maybe, I cannot see any value in putting my name on a list where you can't check where you're on the list. You have no clue about where you're going to get it, but you're on the list maybe. So this is what happened with my mom in Virginia. Is she got to sign up, and she said, well, great, when am I going to hear from you? Sometime. Who's going to call me? Maybe. And it was going to be like, okay, you have your name on a list. She waited hours to do that. I'm not sure there's much hope to that. But if somebody thinks that that would be a good thing, we can certainly do it. We could set that up in a day, but it's not exactly clear to me that there would be any benefit to that. My goal would be that if you're a non-frontline worker, say you're in group 1C, group 6, whenever that's going to be, that when that opens, you call your provider and you get on their list that week, because then if you wonder where you're on the list, you can call the provider and find out where you're at, coming on some big anonymous list. Again, if somebody can convince me that's the thing we should do, that we could do it, we've considered it, we've already set it up, it's already ready to go, but I don't see the value. So Carlos says, could I explain again what part of the population should not be vaccinated? It is a really, really, really small group. So people lower than the age of getting the vaccine probably should not be vaccinated, because it was only studied in people above that age. So 16 for the Pfizer, 18 for the Moderna. So people who've had an anaphylactic reaction to the first dose should get evaluated by an allergist before they get the second dose. People who are pregnant or breastfeeding should check with their doctors before they get vaccinated. I think the recommendation overall is to vaccinate those people, but again, if you have special concerns, other than that, I don't think there's anybody else who should not be vaccinated. Now, people who had recent COVID disease likely have some protection, and they may hold off on getting a vaccine so that somebody who's not had even a single vaccine gets the vaccine, so they'll have some protection. People who've had severe anaphylactic reactions to things like bee stings or to sulfa drugs or something, they should talk with their doctor about the risks and benefits of vaccination. But other than that, I don't think there's anybody who I would say should not be vaccinated. So Kat says, is there something regular citizens can do to encourage getting more vaccine here? I don't know. I mean, the allocation process seems to be, in many ways, sort of a black box. But sure, I mean, if you want to write to your elected officials and put a little more light on this, that maybe you could do that. But again, this is not a county issue. The county has done everything we can do, including the commissioners have been incredibly great. They have been really right on top of this. I probably talk with the commissioners, every one of them, on a weekly basis, and our liaison commissioner is Commissioner Freeman almost every day, and they're right on top of this. So, telling Tim we should get more vaccines, yeah, So only people, this is a state decision. So if you want to talk to your elected officials, it would be your state senators and state representatives. So Casey says, is it true that people with type O blood are significantly less likely to get serious COVID symptoms? Yeah, there is clearly something to do with blood type and susceptibility. We don't know exactly what that's about. It may have something to do with something called autoantibody response. So what we're seeing is that some of the people who really have a lot of illness, they're actually making autoantibodies. So they're making antibodies against their own bodies, which seems to be really causing much of the inflammation we're having, right? So typically what happens is you make antibodies against the virus and kill off the virus. But in this case, it appears that a significant number of people, especially men, who are making these autoantibodies. So the difference with type O blood may have something to do with that. So some interesting stuff. People have tried all kinds of things to see if once you get infected, is there something you could do to be less sick with the disease? And so this is a great one. So there are two things now, or there are several things now that I think are true. One is immune globulins. So Regeneron and Lilly both have these these immune globulin products. So basically, they're antibodies, monoclonal or polyclonal antibodies, that you get an infusion of soon after you get infected. You do seem to have a milder course of disease and decrease the risk that you're going to wind up in the urgent care or the hospital by about a little more than half. There's this drug called Luvox, which is a drug that we use to treat obsessive compulsive disorder. That seemed to decrease your risk of progressing to severe disease or hospitalization by a fair amount. There's a drug called budesonide, which is a kind of an inhaled corticosteroid that just came out today that suggested it could decrease your risk of getting worse and being hospitalized. However, none of these have been associated with a lower death rate. Really, the outcomes in these is, for example, on the budesonide, you seem to get better 1 day earlier. At 2 weeks and 4 weeks, you're a little less sick than the other people. So it's not a home run, but it's a solid single on the budesonide, solid single I think on the Luvox. I think really a solid, maybe even a double on the monoclonal and polyclonal antibodies. There are a couple others that we don't know about. There's Pepcid and ivermectin. Confusing stories on those. Those are pop fly that hasn't landed yet, and so I'm not sure what to make of those. If somebody said to me, "Hey, I just got diagnosed. Should I use budesonide or should I use Luvox?" I'd say, well, maybe. I'd have you talk to your doctor about that. So Michael says, will this pandemic become an epidemic? So, a pandemic means that this is spreading in epidemic proportions in many areas. So this epidemic already did become a pandemic. Will it go back to becoming an epidemic? Maybe. Although I really don't see it. I don't see worldwide spread stopping for a long, long time. So I have a number of male friends who've gotten COVID and their wives have not. Any number of males versus females getting the virus. So we do know that males are much more likely to get really sick with this, and it depends upon the different jobs that they have. Now, what we do know is that the things that are really striking is that there are people who get this and they don't even spread to their wife. I mean, how does that work? I mean, you're in the same house and whatever. We don't really know, and we really don't know why some people spread it to a lot of people, 50 or more people from one person, and then a bunch of people who spread it to no one. We don't know, and that is one of the things which is really, really concerning. But yeah, we don't know why. I just don't know why some people spread it more and others spread it less, right? We have one family where seven out of seven got infected, and then other families where one person gets and doesn't even give it to their wife. We don't understand that. So Reagan says, will students be higher on the vaccine list than the general public? I do not think so. So I do not think that students are going to be any different than the general public. So Ginger says, I had my second dose Monday. Would visiting someone in March who's on chemo be safe for that person? So again, remember, I'll never say that anything is safe or unsafe. I'll just talk about the risks of safety. So visiting someone who's on chemo is always risky because they've got a depressed immune system. And so that there's some risk there. Wearing a mask, as Ginger said she would, certainly makes it safer. Doing it outdoors makes it safer still. Staying more than 6 feet apart makes it safer still. And you, having gotten your second dose, makes it safer still. So what's the relative risk reduction? So doing it outdoors. So let's say the most risky thing, we did it while you were sick, 2 feet apart, indoors for a long period, in an unventilated space. That's probably about the riskiest thing. So you're sick, you've been exposed to COVID, you decide you're going to visit your friend anyway, you don't wear a mask, you sit across from each other for 2 hours in an unventilated place. That's pretty risky. The risk for that person of getting the disease is at least 20%. Now, if you cut down the length of the visit, that probably reduces the risk by half what the original risk was. If you go outside, probably reduces it by maybe another tenfold. If you get the vaccine, it reduces it another tenfold. So now it gets safer and safer and safer. So if you were going to see her, I'd clearly do it outside. I clearly do it with a mask. I do it at a distance, and then that would be on the safer side. So never going to say it's going to be safe or unsafe. So Carol says, are the monoclonal antibodies available here locally? I know there are places that have them. I do not know if there's anybody who's giving them. They are really, really tricky to give. So these monoclonal antibodies were really designed for people in nursing homes. So you'd be in a nursing home, you get positive, you're already in nursing care, you find out early that they have it, there are already nurses there, you give them the IV, you watch them, and the idea was to reduce the risk that you would go to the hospital. Unfortunately, nursing homes have not been able to get it, and so it's sort of out there for anybody who wants it. And as best I know, there's a few places in the state. There's a few places in the state. Ashland is the only one place I know reasonably close that's doing it. But it's complicated because they're asking people to come in who they know are COVID positive. Many of the people are feeling kind of crummy. They don't want to come in. And again, the effectiveness of these monoclonal antibodies is pretty good in reducing your risk of needing to go to the hospital. But as best I can tell, there's no difference in mortality or severe disease. So it's a little hard to know. And monoclonal antibodies have been, I think, the great disappointment. The greatest, I mean, there's lots of disappointments, but one of the great disappointments of this whole outbreak has been what I think is our misuse of monoclonal antibodies. So Bruce says about Viru 111 treatment, got to know more about it. So you have the brand name of the drug or the generic name, I'll know. So a lot of things, what happen is people make a clever name so you can remember it. It doesn't help me. So Julie says, from what I understand, there's a high number of teachers who say they're extremely uncomfortable returning to work. 9% are extremely comfortable, and it's about 17% in between. This is concerning. Well, you know, what I would say is if I was a teacher, I would be in between, right? Because as a teacher, you're in a classroom around 30 other people, 20, 30 other people, most of whom are not going to be vaccinated, some of whom could be really efficient spreaders like teenagers. And so I think it's a worry. I have not been in a room with 30 other people for, I can't remember how many weeks it's been. I mean, I just won't do it because I think there's some concern there. So that's, there is some concern there. It depends upon your risk. And again, people look at risk so differently. There's some people say, I'm 25 and healthy, I live by myself. Even if I get it, I'll likely get over it. And their risk tolerance may be far higher. And so they may go out to a bar with friends. They may go to parties and whatever because they see their risk as being lower. On the other hand, you could be 65, as I am, and you could have a 91-year-old mother, as I do, and you could be caring for them. My mom's Becky, so I'm not. But imagine if I were caring for her, I was now the high school biology teacher, and I would go to school. I would be pretty uncomfortable that either I would get it and get sick myself, at 65 that happens, or that I would get it and not be so sick, but bring it home to my mom. And so I could totally see all of those. So if the 25-year-old teacher says, hey, I'm pretty healthy, and they are extremely comfortable going to work, I would get that. If we have the me who's extremely uncomfortable, I can get that too. And so what I think we have to do in the schools is we have to have the armies of the willing. I mean, if there are people who want to teach in school, they should teach in school. And if there are people who want to teach from home, they should teach from home. And, again, I cannot tell for you what your risk is going to be because there's at least 100 factors that goes in this. Including, I lost my best friend to COVID, say. I could see where you'd be really nervous. On the other hand, you could say, I don't know anybody who's had COVID, in which case you'd be willing to take more of a risk. I can remember, my greatest fear is dying alone. Well, then you really don't want to get COVID versus, look, I do all kinds of risky things, COVID seems like a low risk for me. And again, for me to calculate what your risk tolerance would be and what you would be willing or unwilling to do is nearly impossible. So, okay, so we'll make this the last question. Yeah, so Vero 111, we'll look at that and do that on Friday. Yeah, so Scott says, you previously said there's a certain amount of virus to get the disease. So with that in mind, does taking the virus in small amounts over time build immunity? There is some theory that suggests that's true. It works actually better with allergy. So we know that people who are exposed to something over a long period of time tend to develop resistance to it. So in fact, now a treatment for people with severe peanut allergy is, believe it or not, give them tiny bits of peanut protein so that over time they overcome their allergy. In terms of respiratory viruses, we do not think that works, right? Because we think with respiratory viruses, they're on the surface of your cells, and to build immunity, you actually have to truly get infected. But Scott, I think the answer is still we're looking at it. I went to an incredibly important talk about how masks would decrease the amount of virus you'd get, and you might get an asymptomatic infection that would still provide you enough immunity that you wouldn't get infected later. So I think that's so that's a big question. Anyway, so for Bruce, I'm going to have to look into Vero 111 because I'm not sure which one that is. The one that has been big this week is one called Aplodin, which is a drug extracted from sea squirts, whatever they are, these little things that live in the ocean. And Aplodin is being used to treat multiple myeloma. And in Australia, it's actually approved in Australia to treat multiple myeloma and seems to be effective. Unfortunately, it seems to be effective in the same range as remdesivir, which, as I said, has been okay. It does seem to reduce length of stay in the hospitalization, seems to reduce time in the hospital, might decrease mortality a little bit, but it's certainly not a home run. Okay, so this is the last question then. Can you spread it once vaccinated and with a mask? Yes. What if both people are vaccinated? Much less likely, but still could happen. And are there guidelines for both people vaccinated for gathering? So I got this question yesterday. Hey, I've got a bunch of people and my friends are vaccinated. Can we have a big party? Well, it's certainly safer than if you hadn't been vaccinated. But is it safe? The answer is no, right? Because so you have two people who are vaccinated. The chances are much less that you'll get it. That's why we vaccinate people, but it's still not zero. So it depends upon what your risk tolerance is. So if your risk tolerance is, I wasn't very worried before, then after vaccinated, you should be worried even less. On the other hand, if you're very concerned about this before, because you're living with an elderly parent or you yourself has some condition, that would then be really, really concerning. So again, yeah, both people being vaccinated clearly makes it safer. But please, since you don't know if you're the one who actually got protected, you really should continue to wear a mask. And you really shouldn't get to gatherings. Now, when we get to a point where there are enough people vaccinated and there's very little disease circulating in the community, then I think we are going to get rid of masks. Right? So people say, well, do you need to have a certain level of vaccination to get rid of masks? I think that's the wrong way to look at it. What you need to have is a low level of disease to get rid of masks. So for example, in Taiwan, where there's very little disease, 0 or 1 new cases a day, they basically have gotten rid of masks and social gathering restrictions. So if we get down to 0 or 1 case a day in Oregon, pretty unlikely, but if we got down to 0 or 1 case a day in Oregon, however we got there, through vaccine, through some fabulous new treatment, through everybody really buckling down on social distancing, then yes, we could get rid of masks. But I think right now, with as much disease we're seeing in the community, I would certainly not recommend gatherings and certainly not recommend getting rid of masks. Okay, so Vero 111, clearly something for me to look up next time, and is one of those things you'll hear about on Friday. So again, this is Dr. Bob Dannenhoffer, the Public Health Officer of Douglas County. And again, Douglas County is doing great. A little bit of an uptick in disease this week. But again, what it reflects is people let their guards down and they had gatherings. Got to get done with that. And the other one is that the vaccine really works. So at least in the outbreak that we saw, the vaccines seem to be about 90% protective. So really go ahead if you get the opportunity to get a vaccine, but to recognize we're trying as hard as we can to get as much vaccine out there, but we're struggling because there's not enough vaccine. Our vaccinators have done a great job. I actually went to one of the vaccinator offices today when we delivered the one vial of vaccine. I mean, the vial's only about the size of a Lego man, so not very big. And everybody was treating it like we were handing them a newborn baby, and everybody was so great because they were finally going to be able to give vaccine. So we're doing a great job giving it. We just need more of it, and we do need people's patience. So again, be safe, be kind. Thanks.